हाँ हाँ Sridevi, you have 3 computers now. Sridevi, you have 3 computers.
Yes. Vidya, one is
hosting
here, and the other one is the trainees. 6 weeks trainees are sitting in the training room.
Okay.
So there are 15, 16 people there.
Okay. We'll keep changing this slide once in a while.
It's changing. No? I think Vishnu told me he has kept timer that it will keep on changing every 2 minutes.
Okay. Vishnu, share your mobile number as well. I don't have your contact number.
okay ma'am.
Send an SMS to. What?
sorry.
What did he say?
No, I was telling I can see me, like I thought I'm visible through this laptop.
Okay. I can see all 3 of you.
Sir. Samitra.
ഇത്രയും നാളായിട്ട് എനിക്ക് പോലെ എനിക്കിവിടെ ബാരിയർ ഫ്രീ ഒരു ആക്സസ് വേണം. ഇപ്പോഴത്തെ ഇത് ഡിസ്കണക്ട് ചെയ്തായിരുന്നു
കേബിൾ ഇത്തിരി പാടാണ്. ക്യാമറ
ചെയ്യേണ്ട കാര്യങ്ങൾ ചെയ്യണം. ഇല്ലെങ്കിലും തട്ടി
ഓണാകട്ടെ. ഇതിട്ടേക്കാം. വെൽക്കം സ്ക്രീൻ ഇട്ടേക്കാം. മാറ്റിയേ അല്ല, ഇത് മറ്റേ വെൽക്കം സ്ക്രീൻ വന്നിട്ടുണ്ട്. വെൽക്കം സ്ക്രീൻ ഇടുന്നത്. രണ്ടരയില്ലേ? അപ്പുറത്ത് ചെയ്തിട്ടുണ്ട് സാർ. അവിടെ ക്യാമ്പ് 50 വെച്ചാൽ ഓക്കെ ഓക്കെ. Okay.
Good afternoon, sir.
Hi.
Can we start the session? Hello? Yeah. So, shall we start the session or should we wait?
I think you should.
Okay, sir. So first, I want you to speak about the national policy which has been introduced yesterday. Just a small introduction, sir.
So, Vidya, as far as I know, the policy document has not been uploaded on the website.
Okay, sir.
I mean, to the best of my knowledge, what happened was 2015, they put up a draft policy on the website, on their website, and asked for public comment. According to this, palliative care was mentioned in the introduction, but not anywhere in the body of the document. So we did some consultations, and a few people together created a draft, a modified document, and submitted it. There must have been hundreds or thousands of similar documents reaching the ministry. Now they have, it seems they have formulated it. I googled for the document, and on the Ministry of Science said it will be shortly uploaded. So the announcement is there, and as one of the 4 quadrants in the promo material, fortunately, geriatric and palliative care mentioned. But then it was mentioned in the end of last 8 months. So if anybody ever sees the document uploaded on the government website, please share it. I also wrote a friend asking if he has seen it, he said. Vidya, are there, if anybody has any questions, if you have not understood, you were talking about the new national health policy, which is being launched.
Okay, sir.
Vidya, with your permission, can I bring up something else?
Yes, sir.
To everybody. Like,
yes, sir.
I'm sharing a personal feeling that a cook is a remarkable promise for the future. For many years, many of us have been fiddling with electronic etc. But here is a form of making logic with good management strategy, launched by Sanjay Garover. And I have found it a learning opportunity. And generally, the members here have all contributed. First and foremost, thank you for making it happen. And like today, on the dot of time, so many people are here. I want to thank everyone for making this happen. I also would like to place on record, particularly Nandini's initiative for really pushing us all to do our bit. And also Vidya, thank you for managing. Vishnu, Manoj, thank you for the technical support. We had huge problems here, but I understand that most of them have been solved. But I also have a concern. Like, you know what happens to WhatsApp groups? There is a curve, initially a steep rise in enthusiasm, lot of participation. There were a dozen messages from several people every day, and then it comes. And I'm saying this particularly to Vidya, and Sridevi, but also for everybody in India. I have a suspicion that we are fairly quickly on the downturn of the curve. I find that there were not enough case presentations offered, so there must be a reason. So many people are here, and Nandini was asking me, who are the people who come to me for clinical advice most often? Unfortunately, the persons who come to me most often are not a part of this group. So, Vidya, are we able to take on more members? or have you nearly saturated this group?
We can, sir, because it's not like all the time everyone is present. So we can take more members.
The other thing is to everybody in the group, to the few people who have brought up submitted cases for presentation, thank you very much. But we must be, I mean, I have so many patients in whom I have a doubt about how to go about it, what to do. Everybody must be having those dilemmas. Don't you think we can all make it a point of contributing in a place? I would like Vidya to really be troubled and furrowed for that. And 6 cases, which do I select? Let us all get Vidya to have that trouble of having too many cases to choose from.
We can do that, sir, with short discussions and being up to the point instead of being elaborate. But I would like all the centers to send in more cases. So that's the one worrying point I have.
So, if we are having several cases, I mean, it's just not certainly not a decision, just a suggestion. Maybe we can go by what we do in clinical examinations. One long case and several short cases. So that at least one is discussed in depth with the theoretical background also. And several others we can just clear doubts and move on. I mean, just a suggestion for you all to discuss at least.
Yes, so that will be good, actually. And again, I would like all the spokes to send us more cases so that we can discuss. We want this session to be more interactive rather than us deciding upon things. Thank you. Nandini, ma'am, you want to say something?
Yeah, I wanted to suggest that, am I audible?
Yes.
Okay. I wanted to suggest that as and when the cases come up where you have a question, just put it on record and send it. There is no need that will it be discussed today or next time or whatever. Just ask, because it will be useful for others who are anyway participating. So it's not necessary that we can accept only 3 in every 2 weekly interval. We will accept even 10 or 15, and we can choose 3 from each, or 4 as sir said. I think it's a wonderful idea to have one long and several short. So we can choose, and we will have always surplus of patients and questions with us. So we will just have a bank of different clinical scenario which we can discuss. So it's not necessary that you have to wait for the end of one ICO to think that in the next 1 week, if I get, whenever you get, just put it on record and send it to us. We will keep it and we will start using them. I think that would be giving us a lot of surplus material to work from.
Thank you, ma'am. Sure, we will move on to the case presentation. Shall we start with Dr. Sunil? Dr. Sunil, you're ready to go?
Just 1 minute, Vidya.
Yeah.
To the group, today we are slightly changing the pattern because Dr. Rajgopal is available only up to 4:30 p.m. So we want to discuss the cases and patient questions, and then we will move on to the didactic. That is why a slight shift in the schedule. Okay, bear with us. Thank you.
Thank you, ma'am. Dr. Sunil, sir, you have to unmute and then talk.
I have to mute.
Yes, now we can
Is it
hear
okay?
you.
Yeah.
Yeah.
Okay. So, I'm Dr. Sunil Kumar, presently working in Alpha Palliative Care in Thrissur, Kerala.
Sunil, just lower your screen. No, we can't see your face. Just tilt your. Very good. Thanks.
Okay. Who is going to? Yeah, I can move the slides now. Who is controlling these slides?
Devi, Sridevi, move on to the next slide.
I can't see the next slide.
Sridevi,
Uh,
just move on to the next slide, no? Yeah. No,
Sorry,
the
this is the third slide.
previous one.
This
Previous one.
second slide.
it is changing very well here, but maybe a delay in getting it across to the screen. Sorry for the glitch.
Vidya, maybe we can just talk about sharing screen to all participants so that in future they can be in control, right?
Okay, okay.
Yeah. We can do that at the end of the session today.
Okay, ma'am. Okay.
Next slide. Okay. So I am going to present case history of Master Karthik. He's a 12-year-old boy and he is diagnosed with acute myeloid leukemia in 2015 and he took chemotherapy for that, but he had a relapse. So the oncologist advised HSCT, that is hematopoietic stem cell transplant, and it was in January 2016. After that, he had episodes of breathlessness and fever, and the oncologist told them that it has the transplant was failed and the AML was in relapse. So this patient, we saw him in the home care just 2 weeks back with fever and breathlessness, which was aggravated over 4 days. So this patient was seen at home care. At the time, he was bedridden. He had fever, no cyanosis. He was on nasal oxygen, which was suggested by his oncologist 4 days back. He was drowsy but arousable, but he says he has breathlessness. Respiratory system was within normal limit. He can only speak a few words. He can't speak a sentence. Next slide, please. So the oncologist already told them we can't do anything and send them home. So we knew that he has some infection, but we didn't started him on any antibiotics. We gave him only comfort measures. For breathlessness, we started him on tab morphine, 10 milligram, 5 milligram, 6 hourly, and tab lorazepam 1 milligram sublingual SOS, tab metoclopramide 10 milligram half TID, disoprolol suppository once in 3 days, and tab paracetamol 500 milligram 4 hourly for fever. Regarding the psychosocial history, actually this family is from another district, settled in Thrissur district, but they have good support from friends and neighbors. His father is an auto driver. Previously he was working in army. His mother is a housewife. Both father and mother are very well aware of his diagnosis and prognosis. His grandfather, okay, next slide. He lives with his father, mother, grandfather and a younger brother who is studying in second standard. Actually, grandfather was very emotional. Uh, Mother was not showing it on her face. Um, she has accepted the disease very well, and she also told that um, the patient, that is Master Karthik, he knows the prognosis and diagnosis very well. Father also know about the disease very well. Actually, the problem was with breathlessness. So with the above measures like morphine, his breathlessness decreased to certain extent on that day, but at night it aggravated, and next morning the breathlessness was very severe. So they called us, and our home care team attended the call. When we saw, he was in severe breathlessness, which was not able to control with morphine. So we discussed with mother and father, and they don't want her son to suffer. So we started him on injection midazolam. Injection midazolam was given 1 milligram stat and repeated after every 5 minutes. 6 milligram was needed to sedate him, and after that, um, 1 milligram every hourly was given. Uh, so after 6 hours, the patient died. Next slide. So my question is, our home care team find it very difficult. Not only home care team, entire team find it very difficult to take care of this pediatric patients. They have emotional pain. So is there any way to tackle the emotional pain of the team? We usually don't see pediatric patients. We get pediatric patients occasionally.
Your question is about how can we tackle the emotional pain of the team, or how can we consider this?
Team, our team.
Any comments from this folks? Anyone had an experience similar to that? Please share. Yeah, Mary, Vidya late.
Am I audible today? Hello?
Yes, Iqbal, we can hear you.
Okay. Good afternoon, everybody. I'm glad that today our mic is working today. And I would like to thank Sunil sir for his very nice presentation. And I was wondering whether what was the cause of breathlessness in this patient. First thing, because we are treating the patient symptomatically. We are giving morphine, we are giving midazolam, calm down the breathlessness. But I was wondering whether I don't know what is the performance status of the patient, but I would have done to find out if there is any fluid in the lung, whether any correctable causes are there in the lung, whether any pulmonary metastasis, or if there is pulmonary metastasis, we can't do anything. But if there is severe diffusion, we can do something to relieve his discomfort. This is one thing. And second thing, which was highlighted by Dr. Sunil, was that it is really very painful to take care of the children, really, especially young children, and to watch them breathlessness and painful. I don't have answer how how to deal with these issues, especially how to take care of basically emotional pain. It's totally emotional, how we adapt to it. And you have to, I think, we share with our friends, among the doctors, among the nurses, how do you feel? I think it's sharing mechanism which helps us a lot in dealing with the children. And also one thing, not very much sure. What was the thing which was disturbing the team members basically? Was it breathlessness, whether it was pain or it was suffering of the parents, or with any unfulfilled wishes of the children, what things we should try to understand, what things is what was worrying the team member. Only after knowing that we can help ourselves, This much to say a little bit.
The cause of breathlessness, actually I don't know, because he had breathlessness since some months, and he was visiting his oncologist regularly. So when we saw him, he was bedridden and in a terminal stage. So I didn't want to investigate again and to see what are the causes of breathlessness. So it is futile at this at the end of life. So I didn't actually investigate it for the cause of breathlessness. And Iqbal also asked why the team was emotionally upset. Is it due to a particular cause? It's not actually, I should say, the team members, after caring for the patient, they all felt proud, because many of the people from the locality where the patient was living, they came to us and with their friends and gave us a donation. And also there was a new nurse with our team, and she was actually moved by this episode, because after the incident she told that for the first time she's seeing the patient is dying very peacefully. So it's not about some specific things, but it is I think it is about the general emotional status while we take care of pediatric patients.
Dr. Mary and Vidya had some things to ask. Let us hear them and proceed, I think.
Yes.
You remember I presented the case of that girl with ALL? That's the only case I presented. Well, this girl is in a very bad condition. And in fact, I was with her in the hospital in the morning. She's admitted in AIMS. She has mucositis, which went on to cellulitis of the face. And her whole right cheek and under her submandibular region, it's all swollen and hard and inflamed. So that pain is around 9 out of 10. And besides that, she has the bone pain in her legs, because she's now a case of refractory ALL. So she has pain due to her bones, her legs, and now pain in the face. So she's in immense pain, and she's having high-grade fever, 105, 104, 105 for the last 4 or 5 days, continuously despite the paracetamol IV. She's again admitted in AIMS. So one incident which happened yesterday is she was sitting in the bed, and both her parents were looking at her and crying, you see. So when she looks at them, she tells in Hindi, of course she's a Tamilian, but she spoke in Hindi. She said, looking at you, I get a lot of pain. Looking at you both cry, I get a lot of pain. So her mother says, I want to take your pain, I want it on myself. And you know what the girl said? You will not be able to bear it. Her pain is so bad that she says her mother will not be able to bear it. I was really touched. Those words are etched in my, the conversation that took place. So that is emotional pain, I think, both for the parents and for the child. Now, we don't know how long this girl is going to live, because her leukocyte counts are very low. She's getting granulocyte infusion because they want to buck up her immunity to tackle that cellulitis and all those things. But this is the pain. And she also mentioned something today morning, I don't want to die. Both her parents heard it. So how do you handle this? I mean, I was really touched. So that's what, this is of course a case of ALL, but there is emotional pain going on. The parents, the sibling, younger brother and the girl. I just wanted to share it with you because something that I experienced in the last couple of days.
Thank you, Mary. Can we hear Vidya also and come back to the emotional pain? Yeah.
Hello, I'm sorry I lost you for a bit in between, but I just wanted to share because again, this is a forum where this is the only place probably where we can share what happens. Just like what you had mentioned, that we had a boy with AML. We had AML, lymphoma, all these patients, they come to us in the hospice and then we work around these things too. So it becomes really difficult for us. But this boy with AML, where do we draw the line for blood transfusions? When they come to us, usually the oncologist sends them with a report of 4, with a report of 5. One particular boy stands in my memory because he knew everything about his disease. So he would do the blood test himself and then come and tell me, now give me transfusion. And he says, I know everything. I know that I have so much percent blasts, but my hemoglobin is so much. Now give me transfusion. And how do we tell him it's futile? And how many times? Till there was a point when I said, please don't come, you just call me over the phone. Because honestly, I did it because I didn't know how to accept it. I mean, I didn't know how to deal with it. How many times does he come? How many times do we transfuse him? And then he does the report himself, even if we don't do it. So we understand he's going through pain. He's smiling, he's laughing, but we know what's going on inside. And how does one deal with it? Where do we draw the line for how many transfusions you give till where you pull on? Even if we don't investigate, what if they come with the report and says, now the hemoglobin is so much to do it? So, I mean, it again becomes very difficult. And talking about death with adolescents is probably the toughest. I still haven't managed to be able to do it, honestly.
Thanks, Vidya, for sharing. First, maybe we will address the multidisciplinary team's distress first, which was Dr. Sunil's question, and we'll come back to Mary's and Vidya's question. Is that okay? Anyone has any comment regarding multidisciplinary team's distress when facing the emotional pain? Sir, would you like to comment?
Maybe we can just ask from the team one point as to what could be the contributors to the team's distress as right now, and then probably sir can come back with all those points which are brought forth by the speaking spokes.
Yeah, Mary.
I think that if the team is distressed and is having emotional pain, I think it's a very healthy sign that we are still humane. Okay, so I don't know what Dr. Rajagopal has to say to it, but it only shows that we still have that sensitivity and the empathy in us. And I think it is very humane. That's my comment.
Thank you, Mary. Yeah, Iqbal. Yes. Can you introduce yourself and then talk?
I'm Palaf Kamdar. I am right now working as an intern in the psycho-oncology department at Kachar Cancer Hospital.
We didn't get your name. Can you repeat?
I'm Palaf Kamdar. I am working as an intern at the psycho-oncology department at Kachar Cancer Hospital. So when we talk about the emotional burden that's there on adolescents, a lot of times what happens is that what the caregivers are going through, that leads to another set of concerns on the adolescents. And the child usually takes it as a burden and a guilt to see their parents and their other family members going through something of, to see the child suffer through that. The child sees that. So in that case, in my research, what has come out is, as a result, is that the parents and the family needs to be counseled. There has to be a lot of pre-bereavement counseling done to the family and the parent, and they should be explained of how they need to understand of how their behavior is influencing the child and how the child is feeling burdened and guilty because of the same. So that can help to reduce the emotional distress of the child. So we have the stages of colleagues. Okay, so we have different stages of acceptance and denial and grief. So we need to make the family go through that first. We need to make them understand in order to reduce the burden of the child.
Ms. Kamdar, we were definitely, all your points are very valid, and you were describing the issues related to the adolescent or a child's distress. Here, we are discussing what are the contributors to the multidisciplinary team, the care providers. In this particular instance, they were facing a child one mid-morning. They gave something for breathlessness, and by night, it worsened, and in few hours the patient died under good palliative sedation. The entire episode was pretty short and distressful to the team. We are talking about the distress of the team. What could be the contributors? How can we dissipate it better? How can we handle it better? After that, we will definitely go back to pediatric patients' issues and distresses. If there is no one, then Dr. Rajgopal, please start.
I'm sure some people who are very quiet have things to say. I mean, let me just start from one end. Akhil, can you hear me? Akhil, we are so emotionally burdened, particularly about children suffering. What do you think? Do you have some thought? Speak in English or speak in Hindi, whatever you like. Why do you think we have so much more suffering about our pediatric patients suffering? Akhil is thinking. Betty, do you have an answer to that?
Involved with children because of their innocence, and we are not so happy to see children suffering. So, and usually they will get more mingled to us when we are with them for a long time. So maybe more attached.
Arising from Betty's answer, Kunsho, let me ask you a question. Could it be that when we are dealing with children suffering, we are possibly thinking about our own children? Could that be part of the suffering?
Sir, thank you for the question. Can you hear me, sir?
You can.
Thank you for the question. I attended a 1.5-day workshop by a Professor Tamara from USA in our university here, sir. She delivered a short session on pediatric palliative care, and she said, especially dealing with children with pediatric cases, it's and especially the adolescents, the biggest barrier that the health care provider faces is the communication problems. And she made us do a role play, and then in the first few questions that I asked to the patient as a care provider. She stopped me and then she said, "Okay, Punso, you are out." And then I asked, "Why, Professor, why am I, did I do something wrong? What did go wrong with my session, my play?" And then she was saying, I was not trying to open up the patient, but I was straight away trying to fix the problem. So she said, "Do not hurry in fixing the problem, but try to open up the patient and then maybe go further as much as we can to make the patient open up to us." She said like that. And I think that is one. And the other one is because, yes, as Sir has already said, because most of us are parents ourselves, we tend to put ourselves, put the patient, I mean, think the patient as our own children, and then the emotion just swells up and then we just go numb and we cannot, I mean, say anything.
How many spokes do we have today? Do you know? 17.
Sorry, sir?
About 15, sir.
15, okay.
And
Let me ask a question that where 15 answers at least. How many of us are able to think of our own death, our own mortality? One, two, three, 4, 5, 6. Okay, at least 6 7 arms hands went up. How about
Sir, the entire room of the training center is there with so many of them.
Yeah, there are a few hands up.
But not many hands going up, right? Okay.
Know that they know they can raise the hands.
Like just donation. Thank you very much. Yeah. Now about this last week, when our new 6 weeks course started. I mean, in the first week during one of the discussions, I asked the same question. There must be about 16 people in the team. I mean, in the new batch. Only 2 hands went up. You all have, to some extent, accepted our own mortality. Whereas they hadn't. Now, I would say they would have so much more difficulty in accepting any patient's death, the majority. It takes time. I'm very sorry to have to ask this very difficult question. Most of the hands went up when you are able to think about your own death. And you were able to think about, you were willing to accept death someday. I don't even want to ask the question. Maybe you are not so easily able to accept your child's death. It is difficult, it's very difficult. Maybe that emotional difficulty we have to accept in ourselves. The first answer, I was just trying to organize my answer to this. I think the first thing, hey, wait a minute, I shouldn't come out with my own answer. Sunil, you brought up this case. You have thought about it deeply. Would you like to answer the question? How do we tackle your own question? What's your own answer to your own question? I mean, if you would like to say.
I think there are some points that we have to consider. One is maybe one thing which I think many of us are afraid to control the symptoms of pediatric patients. Maybe because think they may be dying earlier, something like that. I think so. That may be adding to the emotional distress. And another thing is to reduce the emotional stress. If we can control the symptoms very well, and if we look at after controlling the symptom or discuss it in a group, then most of them will feel that okay, we have controlled the symptom very well, very well. So we will get some relief. So I think these 2 points are important.
Thank you, sir.
I was thinking maybe sometimes we feel that if this patient might have reached us maybe a week back, we could have done better. That is one of the feeling that we always go through. Because at the last moment, sometimes we are all helpless. We don't get much time to even talk to the patient and family, going to the distress. So if we can get a chance to treat them bit more early, I think it's more good acceptance from the team's point. That's my personal opinion.
Yes, communication. Communication is an important point, but from our point of view, we were able to communicate with them very well because we were there in their farm for about 3-4 hours on second day, and on the first day about 2 hours. So we were able to communicate with them properly, and actually there were no problem for the parents or for the patient, but the emotional strain was on the team. So as Sridevi told, communication is a very good tool for decreasing the strain.
Nandini Sam.
Yeah, hi. I was thinking that the most difficult parts of being in palliative care, so many of them came together in this patient. One was, intractable symptoms, that is breathlessness, which is very distressing to the patient and to, for all of us to accept that we are not able to improve that much. Secondly, it was a child, as Sir said, all the issues related to child, terminal phase, very little time of total exposure between the palliative care and the family and the patient, and palliative sedation, where the decision is always, we take a decision based on the best interest of the patient, but there is always there is some sense of discomfort when the person passes away. So maybe there are some more. So all these factors came together, I think, in this particular patient. And I was wondering, okay, when we are discussing about contributors, this is what I had to say. And I was wondering whether Sunil had a mortality meeting on this particular patient, specifically for this patient, so that each team member who was involved could interact with the entire team and bring out what is the most difficult part that they faced. Then we would have learned much more about this aspect. I just want to ask Sunil that.
Yeah, actually, I am planning to have a meeting with the nurses. Actually, there were only 3 nurses involved in that procedure. So I personally spoke to all of them. So that's what I have done till now, because as per our working arrangement, I can't physically go and meet the nurses. So that's what I have done. But we are planning for that a meeting.
Thank you, Sunil, because that is one of the evidence-based, solutions to emotional distress within the team, and so that they get a chance to open out. And okay, so I think, sir, this is all I had to interact about this case.
Generally in palliative care, what distresses you more? Is it your patient dying, or is it the patient's distress not being clear? Patient living and dying in continued distress. What upsets you more? When patients are very close to you and they die, at least most people must be feeling very bad, feeling pain. So that's what I wanted to compare it with. Is it that bothers you more, or is it the person continuing in unrelieved pain? You are unable to relieve the breathlessness. You are unable to relieve the suffering.
Sir, I meant what I felt was like, suppose we have had the patient for a prolonged period of time and we have had a chance to control this, control that, do this well. And then they slowly progress and they reach the, little more advanced stage, and we may have to give palliative sedation. There is some sense of us having contributed a lot. But here, everything came together. So we didn't get a chance to get that feeling of having tackled something. Immediately we had to we had to decide upon palliative sedation. That is definitely a difficult decision when a very, very short time interval is given to make that, I felt.
It had nothing to do with your comment, Nandini. I was not even referring to that. But let me ask you the question. Do you feel upset emotionally? Some of us are practically very soft and kind patients, still have a lot of steel in there, can distance ourselves from the suffering and carry on. Many of us cannot. Do you feel more upset when the person dies? Or do you feel more upset when there is unrelieved suffering and pain?
Surely, if I feel more upset when there is unrelieved suffering, not when the patient dies comfortable. I would prefer that, yes.
Others? What do you think? Iqbal?
Sir, we had similar experiences 5 to 6 years back, sir. The lady happens to be a breast cancer lady.
Sorry to interrupt, but we will come back to your experience. We will come back to your experience. But can I get an answer to my question?
The answer is, sir, we really, sir, what Dr. Nandini told us, sir, time is very important factor, sir. Because we had this experience 5 years back, sir, which tells that time is really, because if a patient comes to us and within a few period of time, the patient dies, without being cared, and then we feel sometimes that really we have not done anything and we are just without, what kind of doctors are we, we have done nothing, just gave something and the patient died. So it is really important thing, sir, what Dr. Nandini highlighted. I also feel is that some time should be there before the patient dies, so that, because my story will explain this if I've been given the chance to tell, sir.
Vidya Vishnu's hand.
Yes.
So for the question that you asked, most definitely distress troubles me more. And in fact, I was distressed when Dr. Sunil spoke about it, because was the emotional distress because of the decision of palliative sedation that early? Because even now, when if he would have compared a death of another child where it went in on another track, was the distress lesser than when this child had to be given palliative sedation? Our staff and all of us, because honestly, I don't know how prepared I am for palliative sedation in a child, though I understand it's important. But was the distress because of the sedation or because of the death? Is another factor that was bothering me. So that was one more thing I wanted to raise.
Did anybody else want to answer my question? Sunil?
No doubt it is unrelieved distress, not about dying.
Jennifer, what do you think?
Oh, there's just been too much going on in the background here. I don't know what you were talking about.
Okay, sorry. Farzana, do you have a comment? What upsets you more, death or unrelieved suffering?
Unrelieved suffering, sir.
For the majority. And Iqbal, I mean, I will come back to your story in a second. But even we all agree, when there is not enough time, the suffering is more, or feeling of helplessness becomes more. Do you think, Nandini mentioned the value of discussions within the team? Maybe we have all sorts of discussions, but maybe within our teams we do not discuss children's suffering, and often suffering it not. I mean, discussing that in one session is not enough, because we have to talk about suffering when the child is less than 5 years, unable to understand the permanency of death. We have to talk separately about the suffering of the adolescents who are struggling with adolescent problems, the need for independence, the need for hugs, and still also have to deal with the impending death, which is tough. So many of these discussions are necessary. Sunil, I think, mentioned fear. We are afraid. I think the majority of us feel afraid to tackle a child's suffering like that. It's not easy. It's not easy to start. But once we started, it's actually easier than very often with adults. There's lesser protection. They start opening up more. They are very frank. So it's a question of discussing enough within our team so that we are able to conquer the fear and actually act. There are many other issues. Like often the family will prevent communication. Often you have to struggle a lot with the family before we get a chance to openly discuss with them. But once we start doing it, children usually make it so much easier for us. But for relieving the team's distress, I think an important thing is palliative sedation. And I would strongly recommend, going by Vidya Vishwanath's reaction, that in one of these sessions, maybe we should talk in much greater detail several times about palliative sedation. Vidya, I think most of us have had this problem in the beginning. The first palliative sedation in the team that the team does is very often the hardest. There are always two people feeling this is euthanasia, I don't want to be a part of it. I think discussions is the only answer. And at a certain point, once I was able to address it, then I started feeling, and I now feel it was wrong of me to delay palliative sedation in many cases, because my inability to accept it is actually causing a burden of suffering for that person. But Nandini's point is what I would highlight. Discussions within the team, several times, people eventually opening up and talking about the distress is the, I think, the only way to address that team suffering. And as we discuss, maybe I had not thought about this earlier, everyone, but maybe we need to have a discussion in our team and every team about how to tackle the situation when there is so little time. Maybe our own discussing it will make it a bit easier for us to accept. Granted, when it's just a few hours, last few hours, but that's the way, the time when we get the majority of our patients right. Very often we have dying patients brought to us. This is something that we like to tackle. So within those few hours, what are the most important things that we must do? maybe we need to grapple with that also. I'm not there with all the answers, but my important points: one, we need to discuss enough so that we are aware of our own emotions, our own ability to accept our own mortality and the child's mortality. That acceptance is a big part of dealing with our own pain. And enough discussion to be less afraid. Enough role plays to be less afraid. Hearing enough stories so that we are less afraid. And Full Show mentioned what advice he got. Because as soon as a problem comes, we start trying to fix the problem. Of course, we should be listening a lot before we try to fix the problem. I want your comments about this, but Iqbal has a story waiting. Iqbal, your story.
Oh, no, actually, sir, I want to share the story because Nandini Madam told that time is very important. Because we had a patient 6 years back, sir. He happens to be a auntie of a doctor. So that lady came, with severe breathlessness, and we are enthusiastic about the idea of giving something morphine, to relieve her breathlessness. But just after giving very low dose of morphine, like 2.5 milligram, 3 milligram, then suddenly the patient, collapsed. She stopped breathing. Then somebody, from the doctor's side or somebody from the relative side, patient side, they shouted like that, something like that, morphine has killed the patient. Morphine has killed the patient. So there was a huge rush and cry among, we ran away for giving the antidote, Then we gave, I forgot, then we gave, and the patient again came back, So what I want to emphasize here is that time is really important, We should get some time before that. Ultimately, the lady died after 1 hour or so. But something came to all of our mind, that what has happened was not right, because the patient just came now and we gave something and the patient died, If the patient would have stayed with us for some period of time, if we could have helped her, then it would have been better. We could have prepared ourselves as well as the family members of the patient. This is the thought which I want to share.
The longer we have, the greater the opportunity for all of us to come to some solutions. But then the other side, I don't know whether many people would agree with this, but I really feel that all of us, very often, because of our fears, because of our fear of addressing the issue, delay things so that we do not make use of the time available also. If the patient is coming in the last hour, I know it is very, very hard, and just saying we should have more time doesn't bring us more time. We have to have a plan of action for that, quick communications also. But the important point is we delay vital communications very often too late. When they are reasonably well, they are able to handle difficult emotions more. When they are physically very weak, then those difficult conversations, crucial conversations are more difficult. Repeatedly, just sharing that story and then I'll stop. Repeatedly, I've had this experience of the boy or the girl actually helping the process. The boy or the girl sharing the possessions between the sister and the brother, and everybody starting crying but not permitting communication. We manage the end of life affairs so well very often, but also with a lot of anger against the parents. That's also very common. Lot of anger against the parents who push aggressive treatment, which is causing suffering. And rebellion then. And eventually, I've even seen the child die as an absolute enemy of the parents, and then the parents having to live with this. The answer to all this, I really feel, Sri, we must also be doing much more of this. Just within the team, discussions about this, about handling difficult communication. But I'm sure there are more comments to come up. Jennifer.
The problem that if you're working in a, so everyone's working in different places, and if you're working in a place where I just don't think palliative sedation would be something that would be possible to start in my hospital for many reasons. And so I just wondered if everyone has access to this, or if other people are having those sort of problems as well.
I'm sorry, I did not understand one bit in between. You said the hospital environment does not permit palliative sedation. Is that what you said?
It's not that it wouldn't permit, it's just that I don't think we've ever done it here, and I think that changing attitudes and practice would be so difficult that it hasn't happened here. And we have had I'm not sure for palliative sedation, but we probably have had some patients where that would have benefited them, but I don't know how I would have even gone about doing it, because I feel that there's logistically so many things that wouldn't happen. I was just wondering I was wondering if everyone here is working obviously in Pallium, it's a very good environment, and if everyone is working in a place like that, or if people are working in places where palliative care is having to develop and is having to be assertive against different practice. So I just wondered what everyone's experience was.
There will be many comments, but first I think the perfect answer to the issue that Jennifer brings up, I think can be given by Sunil. Because Sunil has gone through the enormous pain for the first palliative sedation that happened in the hospital. I mean, his first experience with palliative sedation, and where he is now, where within a few hours he was able to take a decision and give a rather decent comfort to the child. Sunil, your journey with palliative sedation. Maybe that would answer Jennifer's question. Jennifer, absolutely. It is not easy, especially when the team has not discussed it. It's very hard. One of the prerequisites for palliative sedation is for adequate discussion with the team. Everybody understanding what exactly we are doing. Sunil, would you like to tell your story, your palliative sedation journey?
It was in 2006 when I was doing my PhD in palliative medicine. There was a patient with carcinoma of the penis who underwent all the treatment and had severe burning pain on both lower limbs and scrotum. This patient was seen at his home and was started first on tab morphine 5 milligram 4 hourly. Actually, he had pain even maybe 1 month back also. That was not under control with any of the medications that was given. Then his wife was telling us that he usually walks around his house nakedly during night because the touch of the fabric itself causes pain. That's allodynia. So why at night? Because he don't want his children and neighbor to see him walking nakedly. So this patient was given morphine 5 milligram, but by next day he developed delirium. So we were unable to increase the dose of morphine. He was admitted in the hospital for giving epidural analgesia. With epidural analgesia, he had some relief, but not a satisfactory relief. So on the day, maybe after 2 days, it was a Sunday while I was on duty. This I always start rounds with this patient first. So when I saw him, he was in severe pain, so I gave him bolus dose of epidural analgesia, and move on to next patient. But whenever I see the next patient, then the call will come saying that patient was in severe pain. So again, I came to the patient, come to the patient, and give epidural bolus dose. By the noon, I finished the rounds and came to the patient. He was in severe pain. So I was sitting with the patient and doing all the things, but his pain was not getting relieved. So by night, I couldn't bear to see this suffering. And actually, his wife was telling me that, please kill him. I don't want him to suffer anymore. So only two of us are here. Doctor, you can inject any drugs and kill him. There is no problem. So I may become emotional while I am talking about this, because still it causes emotional pain for me. So maybe after in the night, actually, I called sir, and he came, and he also tried many things, giving a morphine trial again, and injecting local anesthetic into the places where pain was very severe. But nothing didn't help. So finally, we discussed the option of palliative sedation with patient's wife. So at that time, actually, but my fear was if the patient dies immediately after palliative sedation, will she think that is it because something I have injected that drugs into him? But we had to sedate him that night, and we gave him actually a respite palliative sedation. So in the next day morning, he stopped the sedation, and he woke up from the sedation, and he was able to communicate with his children and wife. But after 2 to 3 days, he actually died. But the fact is that his pain was very much, he did not suffer. So that's what my experience about first palliative sedation. But it was very painful for me. But now, actually, in this child, I was able to take the decision after talking to his parents, because they also don't want him to suffer anymore. So by experience, we will get the confidence and when to give palliative sedation. So the thing is that sometimes we may not be able to give palliative sedation, maybe because the patient's family don't want to give palliative sedation, or we may delay the palliative sedation.
Pardon me for sharing this personal bit in addition to what you said. That night, later you told me that you actually wanted to give up palliative.
Yeah. Actually, I didn't want to be in palliative care because of that incident. So yeah, that's correct.
And there I want to go back to something that Mary said in the beginning. And it's good to feel pain. That's empathy. You are feeling for someone else. And if you cannot feel the other person's pain, then maybe you shouldn't be in palliative care. But this is the other extreme. You can take so much of the pain in that you cannot live with it. Like Sunil on that day wanted to leave it. This has happened repeatedly here in our team. Our first pediatric palliative care clinic. One volunteer and one social worker said, never again. I couldn't want to have anything to do with palliative care. So you feel so upset that you want to run away. So that's the other extreme. And there again the solution is not having to deal with by oneself, by sitting together as a team and talking about it. So before we started the palliative sedation, the next day, we had a discussion in the team, remember? We got as many people in the team involved as possible. The first day was temporary sedation. The next day, we allowed the person to wake up to see if he was any better. But then we had to make sure that the whole team discussed this. So, I mean, like putting it all together, important points. It's good to have for the team to have pain, but there is only so much we can take. The pain comes down when it is shared. We share our suffering. We make ourselves clear in our minds about the right and wrong of it. Particularly Vidya Vishwanath, we struggle with this. But when we discuss with several people, exchange ideas, we get clarity in our minds. This is the only thing that I can see. Sunil and I couldn't have done anything else in Sudhakar's. There was nothing else. And this we had to do. And that is something, that clarity from discussion is something that we are seeking for the whole team. And when we discuss like that and arrive at some solutions together, then our fear factor comes down. We are less afraid. We are less afraid to face the issue. And my final point is, and when we just plunge into it and talk to children, very, very, very often, they make it easier for all. They help us more very often, not all the time. There are no guarantees. But Nandini, your hand had one.
Yeah. Going back to Jennifer's question, that there is not enough of an environment to start palliative sedation in her hospital. I was wondering whether it's the question of the palliative care team alone, or is it also the environment of the hospital itself? So if it is the hospital, sorry, sir, you're saying something, I can't hear you.
Sorry, Jennifer didn't say that the environment was not right. Those were words that I put into her mouth. That was wrong. She didn't say that. She just said their palliative care at that level of development, when they couldn't even think about that. Jennifer herself has less than 1 year of experience, and a team getting together and discussing this has possibly never happened. Sorry, Nandini, I just wanted to correct that because she said she didn't mean the environment. It was a problem of the team.
Okay. So I don't know whether it is it's the duration of palliative care team experience that is going to determine, or it is the indication for a particular patient. Because I remember that the first patient that I went for home care as a follow-up, when I reached there, all that I could do was palliative sedation. So this was my first experience in 2000. So I don't know whether it's related to the maturity, or of course the decision making should be based on the criteria that sir mentioned. There should be intractable symptoms. All the other measures would have been tried and the interactions with other disciplines have been done. And we know that this symptom is intractable and sedation is the only possible solution for that symptom. There should be there should be adequate communication and understanding with the family, with the patient. As sir said, to begin, even in a child, there are ways of communicating. There should be acceptance within the team that we are doing the right thing, and the intention is symptom relief. Intention is not anything else but symptom relief. And then, as Sunil said, begin the sedation and lighten it, and see what is the right level of sedation, so that we know that we are not overly doing the sedation. So the minimum sedation which can manage the symptoms is all that is necessary. So we know that our intention is symptom relief again. By monitoring the level of sedation, we are assuring that. So I think all these points are relevant when it comes to doing the sedation. And more, I think, as I emphasized earlier, a meeting for each difficult case, especially when the symptoms have been intractable and especially when we have given palliative sedation, focused discussion on that particular patient's issues and the way it happened. We can have a discussion of, have we done all that we could do? Do we do things differently next time such a patient comes? Is there anything that is undiscussed about that from any of the team members? Something like how, we can call it mortality meeting, but completely a different focus than what happens in other, generally hospitals. So all these together can bring in the team in clearly understanding palliative sedation as one of the tools available to a palliative care physician to handle symptoms. If we can keep the patient, conscious and symptom free, of course we will do that. That will be our first choice. But if the conscious patient is not being able to, we're not able to control the patient's conscious level as well as the symptom relief, then we have to bring down the consciousness level, give sedation, and give priority to symptom relief. I think that is my contribution.
Back to you,
Vidya.
Yeah. So we'll summarize and move on to the next case, if that is okay. Or if you want to continue the discussion also, it's fine. We'll do the rest of the case presentations next session.
I highly thought I had done a summary. The answer to Sunil's question from my side was again the discussions within the team to make sure that we are able to accept our own mortality and children's mortality also. That, and with discussions we'll convert fear to a certain point so that we will accept that some people will have intolerable suffering. And the general group's unassailable position is that if there is time, it's easier. I added the point that when there is time, very often everybody, including I, waste the time so that we do not start crucial conversations early enough. People are able to deal with difficult emotions when they are physically reasonably well, rather than when they are very weak. That's my summary. Discussions within the team as the answer.
I have some more points from what we discussed as a summary. That is, one is the distress of the team could be due to difficulties in approaching the symptoms of children itself. We are always a little worried whether are we going to harm the child more even with our symptom relief medicine. So especially when it comes to sedation, we are even more fearful about our decisions. And and second thing is, if we have reached palliative care after a good amount of symptom relief has been achieved, then the team feels better because they feel that they have contributed, and then this has happened. I think these are the only two extra points that I had noted down. Yeah. Thank you.
Thank you, everyone. And next will be Dr. Jennifer's presentation. Sridevi, we are ready with that? Jennifer?
Hello, everyone. Can we go to the first slide?
Sridevi, move the slides.
I apologize if this presentation isn't as in detail as it might be. This patient I saw a long time ago, I think before Christmas. So it was a 53-year-old lady with, she came in, this was her first presentation to anywhere, and she came in with a 2-week history of breathlessness and weakness. Quite a quick deterioration from her previous state. And she was diagnosed subsequently with a left-sided lesion in her lung and mediastinal invasion and metastases elsewhere. Oh, next slide. So when she first came in, she was breathless, tachycardic, drowsy, and there was reduced air entry on the left side. And she was, at that time, she was drowsy, and I think from when she first came in, she really wasn't able to give a proper history. It was her family giving the history. So when you felt her abdomen, you thought there probably was some tenderness sometimes from her reaction, but not all the time. And she was obviously quite unwell. Next slide. So she was given initial treatment, nebulizers, steroids, antibiotics, serofilin, and fluids. This wasn't by the palliative care team initially. This was by another team, the admitting team. And she was a bit anemic, so she was given erythropoietin, and she was already started on antibiotics for the high white cell count. So she obviously had this breathlessness, and we felt, so there was an attempt to do a tapping of the fluid, but so we went for ultrasound guided marking, and but they said there was no tappable fluid. So I think that the chest X-ray, actually a lot of it was collapse or mass, so it wasn't possible to tap the fluid. Next slide. So the two things that she did have symptom-wise is pain and restlessness and breathlessness, so 3 things. So she was started on a buprenorphine patch, Buvalor patch, and also given droteverin injection twice a day. And this is over this isn't all on the same day, this is over a period of a few days to a week maybe, where she was, for the restlessness, she was given haloperidol, and that was increased to 2.5 BD, and she was given alprazolam at the same time at night time. And she continued to deteriorate and was transferred to ICU, had a virus tube inserted for giving medication, and then, I'm not sure, this last bit possibly isn't correct. She did die sometime later. She was admitted to ITU, then she came out, she was transferred back to the ward, then she deteriorated again and was admitted back to ITU, and then she died in ITU. So family history, social history, I don't actually know that much about, but she was married with 1 son. There were some financial constraints, although they still agreed to have her admitted to ITU, which is quite costly. Next slide. So the reason I brought up this, so also when she was admitted, she had, she underwent a CT scan of her chest and abdomen, and I think that's the only other investigation. But so there was, even when she was very poorly, there were still plans to investigate her cancer, because we didn't have a clear diagnosis of cancer, as it was the first time she was presenting to any hospital. But the reason I brought up this case is, first is that the ethical dilemma of continuing to investigate a patient when obviously they are they're deteriorating, and knowing what cancer they have won't change necessarily the management of them, as their palliative management, supportive management really. And the obvious problem with admission to ICU at that time. And then the other thing I wanted to ask about was that this patient was quite restless and short of breath and possibly in pain, and she couldn't take oral medication after a time because, well, she could have medication in her bowel tube, but and we don't, in my hospital, it's difficult, especially if a patient is in that intensive care or even not. We don't really give subcutaneous medication. So my question is to know how to manage these terminal symptoms or palliative symptoms, how to manage them where we can't really use subcutaneous medication. So there is an option of oral medication or topical patch or intravenous medication, but it's quite a dilemma, really, so that's why I brought up this case.
Thank you, Jennifer. What was the detroverine being given for? It's an antispasmodic, right?
So I think it was being given for possible abdominal pain. It's quite commonly given in this hospital for abdominal pain in case there's some sort of smooth muscle spasm.
Okay, thanks. So is your question more about this kind of ethical dilemmas that happen within the team as a decision to be taken, or because the team has to work with non-palliative care specialists and it's an overall decision that finally reaches the patient? Do you get patients entirely under your management? The palliative care, does it get the team, get the patient under their own management?
So we do have patients under our management, solely under our management, but if a patient is transferred to the high dependency intensive care ward, then they are managed by us and by the intensive care doctors, and so then it's a little bit more difficult to manage the patient. For example, the doctors in intensive care are slightly worried about any medication that if a patient has breathlessness or is admitted to intensive care with respiratory distress, then they will probably stop. If they're already on morphine, they will probably stop their morphine because they're worried that it will cause deterioration, respiratory depression, and they're worried about these medications causing. So if you're thinking about something like midazolam or any medications for that sort of thing, they're worried that will cause sedation. So then they're worried because the patients are often hemodynamically unstable, so they don't want to give those medications. So, and my question is that obviously there are a lot of, obviously palliative care isn't perfect in a lot of places, and there are things that we need to develop and push forward in the future. But my actual question is how to best manage these situations with the situation that we have at the moment, how I can best manage by still giving some medication, by being confident to say, no, it's okay, please give this patient some midazolam. I'm happy for you to give it intravenously, small dose, things like that. So it's not, I know that we need to change the system in the future, and we are working towards trying to reduce admissions to intensive care anyway, but it's how to deal with the current situation that we have.
How many of, okay, sir, please go ahead.
I actually wanted to ask you or anyone else. Jennifer's, that institution has been struggling with this for a long time, where palliative care is still very subdued and they are not able to limit aggressive interventions in the end of life. That has been going on for a long time. Nandini, you entered a corporate hospital and caused several transformations within a year or two. Maybe others have also achieved this. So if truly you share the difficulties, maybe and how you overcame them, it will be educative to a lot of people, including me.
Sir, I will definitely share, but before that, I want to know how many, those who are connected today, how many of you work within a hospital setting? Can I know? Betty does, Akhil does, of course, Jennifer. Udya, can you see any more? Because I can't see all the screens.
Iqbal is there.
Iqbal is there.
Yes.
So first I would like to hear from Vidya and Betty and Iqbal. And then I will definitely share whatever experience that I've had. Vidya, how about you first? Why don't you start? About, getting palliative care within the culture of the hospital when we have a hospital-based palliative care.
Hello. I don't know if I completely qualify for this because ours is an outpatient setting and it is integrated into an oncology setup. So what happens is the oncologists, they refer patients to palliative care, and we are on three different, hospice is in another hospital. So the hospice location is in a missionary hospital. The oncology center is an outpatient palliative center, and a foundation supports the hospice. So that is the kind of triangle we work around. So our integrating into the hospital, into the oncology center is only possible because the director and all of them are pro palliative care. It would be very, very hard if we had a center where they did not want us around. It would be really hard. And even in the hospice, because it's run by a missionary center, it is not too difficult to integrate. But having said that, we see that most of the admissions in the hospice, almost 90%, are from the center I work in, though there are 3 or 4 other cancer hospitals. So, and it is not that they are not aware. All of them are aware of the hospice, but even then, getting a referral from any of these centers becomes very difficult, and when they come in, it is when they are dying. Having said that, the only thing is they do not interfere in the management. But when we get cases very, very late in the day from these centers, whereas from our center, it's way earlier in the trajectory. So that is the kind of experience we have here.
Thank you, Vidya. Betty, could you share some of your experiences? Unmute yourself, Betty, please.
I work in the hospital setup with Ceroli with the oncology department. So actually I just started in, so I don't have much experience to share. But for the time being, I'm working as part along with the main oncology team. So I'll just have to support in the treatment, that's all.
So do you get sort of an independence to take care of the patients who are referred to you for the reason that they are referred to you? Or do
Yes,
your prescriptions get changed?
No, I'm allowed to do whatever it's required.
Have you had any reference about patients who are in the terminal phase
No,
recently?
not yet. Not yet. I just started it. It's only a month now, so not yet.
Thank you, Betty. Iqbal, can you share some of the, experiences, especially regarding autonomy that you have regarding palliative care management of your patients who are referred to you? Autonomy. How much autonomy do you have?
In this regard, I am very much fortunate, madam, in that I am very much autonomous here. Whatever I do, basically, after getting training from Pelim India in 2009, I am just autonomous, basically. In that way, in the sense that we have a very close, coordinated, as well as very well integrated system of department here. Whenever the patient is referred to us for palliative care, first they are referred either from the OPD department, or when the patient is inoperable from the surgical department, or they may be referred to us from the other chemotherapy or high dependency unit that this patient is for palliative care. So the flow is very streamlined in our OPD. If the patient are able to walk, we get to see me in the OPD, whether it is an OPD patient or from the indoor patient. We have to go when the patient is in ambulatory, non-ambulatory. And also we get referral from outside physician. Now, due to the advocacy program, as well as due to the increased awareness of palliative care in our case, many doctors from the medical college, they know us that we are doing this thing. Instead of referring outside, they send directly to the palliative care department. So and so doctor is there. He will give you some medication for pain relief, symptom relief. So we go there. So once we say that the patient is for palliative care, we give all the symptom management. So if you think that the patient need very acute symptom management, we discuss with the attendant, we get them admitted, and we try to control the symptom in very fast as possible within 24 hours or 3 days, or so that our most of the symptoms are narrowed down to less than 20% or less than 2 by 10. So once the patient is stable, we discharge the patient. And once a week, we have a multidisciplinary tumor board. We had the very good opportunity to sit along with all the oncologists, discuss also the death audit, as well as we do, this patient is for palliative care, why don't you give some other chemotherapy? So we do a very good tumor discussion, which gives us a very close access, very detailed access, and give good knowledge about the oncology management also. So,
Iqbal, how did you manage to get this much autonomy? That is something that we want to really know, because you got to do advocacy programs within the institution, and you are part of the MD team discussion. How did you manage to make that happen? Was it just given to you, or you made it happen?
No, thing is that it is both way, madam, because in our setting, it is different basically, because we are a very philanthropic organization and have very few members here. So we have to support each other, because I am an anesthesiologist. I give anesthesia sometime also, very rarely. I also do I have to multitask myself in doing many things. So, and another thing is that head of that is director of our Kachar Cancer Hospital, he is very much moved. He is very much into, he has very good knowledge about palliative care also, and he is mentally also very much prepared for giving palliative care activities. And so in one way, our director is very much supportive over the palliative care activity. We understand what palliative care is. And most of the work which you do in our hospital, these are just, I mean, many of the hospital you can see, madam, because they have the tendency to catch their patient. This is my patient. I have to earn a lot of this patient from the patient before I could send the patient to outside. So the oncologist has the tendency to keep the patient to him as long as possible. He can take something out, to keep his respect, earn some money, something like. But in our hospital, because we are a full-time hospital here, so we don't have this. Because all patient, if anybody patient comes to our hospital, it is our patient. It does not matter that oncologist sees the patient, GI oncology or any surgical, because once a patient comes to the hospital, it is my patient. So whether doctor sees or doctor oncologist sees or radiotherapist sees, ultimately the patient will be coming here. And so we have to think as a whole that our institution should grow as a whole. And if your institution grows, people will come to us, will get more salary, will be satisfied. So this is the close, team, in our, which helps us in doing this work. Basically, this is our team effort, as well as this is the main motivity what we get, madam, in dealing with the patient.
Okay. Thank you, Iqbal. Was there anyone else from a hospital setup who wants to share? Or were these, Vidya, did I miss anyone?
It was Jennifer, since Jennifer asked the question.
Yeah, Jennifer asked the question. Yeah. So what generally has come up from the discussion is, one is a pro-palliative care person at the management level. Both Vidya Vishwanath as well as Iqbal had the support of a pro-palliative care chairperson or the medical director or someone. So that is one important component, but I cannot say that is the most important component. That's a helpful component. I think a more important, like even I had initially met when I went to, as Sir said, when I went to this particular corporate hospital, after my interaction with the chairman, the last sentence told to me was, Dr. Nandini, there is no terminal care in this hospital. So because that was not part of their agenda at all. So it is not that they have palliative care, some ideas, but when it comes to end of life, it's a completely different thing. And all the aggressive interventions, like whatever reason that Dr. Iqbal is giving, that oncologists feel ownership to the patient and they try to do their best is important, but they also do not know the scope of including palliative care in the different aspects of the patient care. So one important thing is getting the management pro-palliative care. That is only possible, if they are not already, that's only possible through feedbacks. So I have used feedbacks from patient relatives several times, both in 2 hospitals which are, I have worked in, where I've began the palliative care services and the department. Both of them, I would use my own patients' relatives when they come back to appreciate after, say, symptom relief or even a satisfactory symptom-free end of life. When they come to appreciate, I ask them, will you be able to write this down and address it to the management? I think that's an important loop that we need to complete, because the management has to know about what work we are doing. Otherwise, the patient comes into our section, everything happens well, and nobody in the hospital gets to know about it. So we need to complete that loop by having the relatives feedback to the management. That is one part. Okay. The second part is networking. Both Vidya as well as Iqbal have the advantage, and Betty, all of them have the advantage of different roles. Betty is part of the entire oncology research team. Vidya is part of the hemato-oncology team. Iqbal is an anesthesiologist. I was an anesthesiologist. So all of us had some way in which we could, we already had, sort of ways to interact with the hospital, different professionals and different department heads, etc. So that, we are able to talk together. So that networking aspect is very important. So Jennifer, you will find someone within the team. For example, I don't know if it is Rakesh Roy, who is an oncologist, who is part of, sort of a important palliative care person also in your department. Maybe that should begin from there. Now, so it is important that the team member from palliative care has foot into the other departments in other capacities. Then that is one way of beginning the network aspect. Another thing is begin to take rounds with the oncologists. When they take rounds, we take rounds with them. Take permission beforehand. There will be, if there are 100 oncologists in the hospital, there will be at least 2 who would have gone abroad, done part of their oncology and come back. And whoever has gone abroad and had a training in oncology would have had exposure to palliative care and the integration of it within the oncology work. So find out these oncologists. They will be currently in their mid 40s, because they would have gone and come back with some training. And those are the oncologists you can begin with. They immediately understand the language which palliative care doctors talk, and they would allow for, you can ask for permissions to have joint rounds and then make suggestions. They may or may not accept the suggestions, but once they do and they see some changes in the symptoms, that is their main thing. If they can relieve symptoms earlier, they will feel happier. Third thing is, as Iqbal mentioned about team discussions, there will be some academic activities which are institution based. Again, we need to get whoever is in charge of making that academic program and push some of our patients' case presentations into that, so that people understand what we do. Very often, most people within the institution also have poor understanding of what happens in the palliative care unit, because there is not enough reverse communication. Patients come to us, we treat them, they go back home, and there is never a communication back to the oncology unit, especially when the patient is in the late stages. So it is a good idea to send a patient who has come in a very difficult stage. We put him on a wheelchair, but send him back to the oncology section, so that just to say hello, so that they see a fresher looking, a little more energetic patient. May not be that we achieve this in all patients, but whenever we achieve, please make sure that you send the patient back to the person who referred it to you, so that they get to see that person, and bring patient discussions, especially where symptoms have been managed, and bring it up in the academic session. So these are different ways of networking. And all this, and of course, mortality meeting. Ask for time, and as we just discussed in the previous patient, we could make one of the mortality case discussions as one of the end of life care that we managed. And I can just suggest you one story about resistance of the hospital in getting end of life care happen, and how I sorted out in that particular instance, which I learned a big lesson. There was this patient who was repeatedly being platelet transfusions. He was an extremely well educated, extremely creative, and fantastic patient. And I was looking after his symptoms, the other symptoms, and his other palliative care issues. And he kept telling me, "Doctor, I just don't want any more of this platelet transfusion. I know it is going nowhere." Literally 3 or 4 times a week he used to get this, sometimes several times a day. He didn't have issues with money, but that was not the point. It was too much for him. He said, "I am ready to go. Please help me." And I, being, a little, I didn't think too much. I went and approached his oncologist and said, "A patient is asking for this. How about, reconsidering this platelet transfusions?" I was told that, "Dr. Nandini, please look after his symptoms and leave the rest to us. Don't let us, disturb all those aspects. We know what we are doing." Then again, I continued my symptom management, and the patient insisted again and again, "Please do something about it." But now I was little more, understanding about how to approach. And I told him, "See, this is very clear to you. Why don't you tell this doctor the next rounds that this is what you want?" "But how can I tell?" Then what I did was I sat with him and had a sort of a role play as to how to tell this to the oncologist and what possible responses may come and how to respond to it. So the second time the patient asked me to tell, what I did was teach him or coach him how to tell this to the oncologist directly. And then after that, the oncologist has no answer. He cannot force a platelet transfusion on a patient who's very clear they don't want platelet transfusion. So then the oncologist comes back to me and says, "It looks like now we need to look at end of life care, and can you please do something about it?" And so then the request comes from the oncologist. So, if we go with the end of life care plan to the oncologist, it's very unlikely to be taken. But if the patient asks, and if we can support the patient, and that requires some amount of rapport building, that helps. This is one instant I would like to highlight here. And so this is about overall getting the palliative care concept. I think several of us now have shared some experiences. It's definitely not comprehensive. I think Sipla wants to share something, but just give me one more moment. That was just to, Jennifer brought out about how to use subcutaneous infusions where it is not being used commonly. But I mean, nobody's stopping us. It is an accepted way of giving medications. We just start it. If it is not being done, we do it. And we give the advantages of using that. We talk about the difficulty, and, about the effectiveness and all those things. And just we begin it. It's not necessary that everybody else has to be using that. We can begin. And it is a very well accepted medical technique, and I don't see why that could be an issue. But if there is some particular issue that you want to discuss about subcutaneous infusion, please, we can take that after Sipla shares something that she's trying to tell us.
Sangeeta.
Yeah, thank you so much, ma'am. I totally agree with Nandini ma'am what she said. The networking for the oncologists is very important. And along with that, when we are talking about the hospital where we have palliative center, there we can have a talk with the staffs who are working in the oncology department, the nursing department. Okay, so that they, along with their treatment, they can communicate with the patients side by side and teach them about the palliative care where their patient is not aware of. Okay, so that would help, and that can be taken along with to the oncologist. I'm audible?
Yeah, you are audible, but what did you say? The second point was the nurses? You said?
The nurses can be taken into concern, and the nurses who are working in the oncology department, oncology wards, where the patients are taken care by the nurses. So they can be taken into the loop and taught about palliative care, and that can be communicated through them to the patients. So that can be indirectly gone to the oncologist also. So that's a
great point.
Yeah, awareness. So and oncologists very important because they don't directly give the patients to palliative immediately, but we have to give a lot of awareness to the oncologist as well to give the patients side by side the treatment will be going on and the palliative is also taken care of. So that would be very helpful.
So this is, I think, some amount of recommendations have come together regarding Jennifer's question. Jennifer, do you feel okay, or do you have a burning question on this?
Just that so you're right. We could start subcutaneous medication possibly on the ward, but if we tried to do that, at the moment we wouldn't be able to do that in intensive care because the doctors are taking ownership more of the medication than us. And so then I'm just a bit stuck with. Then I feel that there aren't medications that I can give, and I find it difficult to get information about what I could have. I mean, I know it's not a good way, but if you wanted to give some intravenous medication, I find it difficult to find the information because obviously that's not how palliative care is done. So, and it's not the best way. So if you look in the books or they don't give any information for intravenous doses. As in, what I'm saying is intravenous is maybe better than nothing. If you can't give subcutaneous, maybe intravenous is better than giving nothing. So, and I can't find those doses, and so then I'm not able to confidently say. If I was more confident about what could be given, I could then be more confident in arguing my case to the intensive care doctors.
My answer to that point would be that definitely subcutaneous doses you can give intravenously for sure, and then probably titrate it, right? Because anyway, there are dose ranges. So subcutaneous is absolutely safe to be given in intravenous route, and then scale it up if necessary, or scale it down. Most probably that would be the one that would be required. That would be my take on that. So I think we will hold this discussion right here because Vidya is, I think now it's only half an hour left, and Raji has much to tell us about best practices in opioids medical usage?
Yes, ma'am. We will move on to the dietetics, and if we have time, we'll come back to the discussion. I'll also share some articles regarding. Yeah. Dr. Rajasree.
Good afternoon. I am continuing Nandini's sessions. Her session was, it was on 3rd March, I believe. It was on best practices for medical use of strong opioids. So my talk will be in continuation to that. The topics for today, which I would like to go through, because it is a huge and vast topic, but I will be focusing more on the following subjects, more on the following areas. Am I audible?
Yes, ma'am.
Monitoring patients on opioids, routes of administration, equivalent dosing and opioid rotation, interplay of pain and delirium, opioids in liver disease and substance use, and few self-assessment questions. So let us first look at how to monitor a patient on opioids. So first of all, as Nandini had already described, the 4 A's, which are cornerstones in the assessment of a patient who is on a specific opioid. The first is, of course, analgesia. Well, all of us are very particular and pertinent while recording the pain score and how does it look like, what kind of pain it is, what quality and where all it radiates, and the rest of the case sheets show no follow-up for that. So when we look at analgesia, we have to go back to the previous pain score and then compare with the present pain score with the previous one. Then only we will be getting an exact estimation of what analgesia that particular analgesic agent had provided. And then while checking for analgesia, if the patient doesn't feel the expected pain relief, check for the complaints as well. What are the reasons for the inadequate pain relief? Is it because we selected a wrong analgesic or we used a suboptimal dose? Or is it because the patient is not taking the medicines as per the prescriptions? The reasons could be many. But if we want to know the exact reasons behind the non-compliance, we need to repeatedly ask the question whether you have taken the medicine according to the prescription. You ask specifically whether you have taken the dose at 10 o'clock or 2 o'clock. Sometimes we do have to do that. And then comes activities of daily living. That means functionality. Am I audible?
Yes. Yes.
And see, activities of function, and the ultimate aim of prescribing an analgesic is not absolute pain relief. It is to improve, it is to provide pain relief, of course, but also to improve the functionality of the patient. So we need to focus if the patient could enjoy a comfortable night's sleep, if he could enjoy his meal and drink, and if he could have a comfortable seating, and if the patient was able to sit previously, if he was able to get up and walk few steps. This is very important. And whether he was able to sleep comfortably, and along with that, whether he was able to communicate with his family members, friends, and other people in a normal way, near normal way at least. And then adverse effect. What are the possible adverse effects to our prescriptions? Definitely we should go through, we have to keep a checklist while asking this question. And while checking for the adverse effect, never overlook the side effects as well. And then look for the aberrant behavior. This is very important because though it is not very common, substance use can be a big issue in our country. So we need to focus the so-called illicit behavior in a patient, or it could be from a family member as well, who can misuse the prescribed tablets. So we need to focus on that aspect also. While checking the analgesia, functionality, side effects and adverse effect, and the aberrant behavior, we need to focus on the other symptoms as well. The presence of other symptoms which remain unrelieved can affect the quality of pain relief. Next slide, please. And then comes routes of administration. Oral, I have just listed most of the routes like oral, rectal, parenteral, epidural and intrathecal, oral transmucosal, nasal, transdermal and topical. So oral we can see most of the opioids can be given comfortably except fentanyl and buprenorphine. Buprenorphine anyway it is not being used commonly. Morphine, methadone and tramadol can be safely given orally, and morphine and methadone can be given rectally as well. Morphine, fentanyl, methadone and tramadol can be given in parenteral route as well. Parenteral, when I say, I mean both, all intramuscular, intravenous, subcutaneous. Intramuscular route is not popular in our palliative care practice, but for the completion's sake, I should mention that also. Epidural and intrathecal routes are particularly useful for morphine and fentanyl. Without the addition of local anesthetic or clonidine, we can use. And methadone is not very popular in epidural and intrathecal routes. Oral transmucosal route, buprenorphine can be used sublingually, and probably that is one drug which can be given sublingually. And fentanyl is another drug which can be given oral transmucosal route, but it is given as a buccal. We don't say sublingually, it is given as a buccal preparation. Nasally also we can administer more opioids like morphine, methadone and fentanyl. And fentanyl and buprenorphine are the two drugs which can be given transdermally. And topically also, opioids are quite useful. Morphine can be given intra-articularly and it can be applied on the wounds, both malignant and non-malignant wounds. Next slide, please. And coming to equivalent dosing, oral to parenteral morphine. If it is subcutaneous, the ratio is 2:1. And it is intravenous, it is 3:1. Oral morphine to transdermal fentanyl, on the other hand, there is no direct conversion tables. It depends on the 24-hour morphine requirement and we have to calculate and follow the table accordingly. And whereas parenteral morphine to parenteral fentanyl, there is a definite equianalgesic dose like 100:1. And while coming to methadone and morphine, it is highly variable depending on the interpatient variability and the total morphine dose. I don't have any personal experience in using methadone as well as fentanyl. I have taken these details from the textbooks and the available literature. It is said that when converting to morphine to methadone, when the total daily use of morphine is less than 90 milligram per day, the ratio is 4:1. And when it is between 90 milligram to 300 milligram per day, the ratio changes to 8:1. And when the morphine dose exceeds 300 milligram per day, the ratio becomes 12:1. It is a bit tricky. And then again, parenteral morphine to, oral morphine to oral tramadol is 1:5, whereas parenteral morphine to parenteral tramadol is 10:1. Next slide, please. Now coming to, I am rushing little fast because I need to complete the presentation so as to give the group to have a discussion if possible. And coming to opioid rotation, it is an approach to reduce the opioid side effects by switching to an alternative opioid. And the whole process requires lots of familiarity with a range of opioid agonists with the use of equianalgesic tables to convert doses when switching between the opioids. And while doing opioid rotation, we need to consider that the patients will be at risk either under or overdosing by virtue of individual sensitivities. This is a very important part. And let us look at the main indications for the opioid rotation. Occurrence of intolerable adverse effects using dose titration, adverse effects, and then poor analgesic efficacy despite aggressive dose titration, problematic drug-to-drug interactions, preference or need for a different route of administration, change in clinical status. It could be concern about the drug abuse or the development of malabsorption syndrome, particularly for oral opioids, or a clinical setting that suggests benefit from an opioid with a different pharmacokinetic property. And definitely, last but most important, financial or drug availability considerations. Next slide, please. While doing opioid rotation, we need to remember dosing must be titrated to individual response. Though equianalgesic tables are existing, we need to look at the patient's response while switching from one opioid to another opioid. And remember, cross tolerance can occur among the drugs. While doing opioid rotation, it is recommended that to begin with a dose which is 50% lower than the equianalgesic dose, and then increase gradually depending upon the patient's response to effect in a satisfactory analgesia. And while doing so, the caution should be there for elderly or debilitated patients and patients with hepatic and renal dysfunction. Let us look at the complex interplay of pain and delirium. So the catch is that unrelieved pain and opioid overdosage both can result in delirium. And in a delirious patient, conventional methods of pain assessment could be difficult. We cannot show them a pain scale, or we won't be able to get the severity also exactly. So if we are in doubt, before going to that, and we have to rule out all other causes of delirium and discontinue all non-essential centrally acting medications. This is to rule out other causes which are likely to precipitate or make the patient delirious. So if you are in a doubt whether the patient is in pain or whether the delirious status is due to morphine overdosage, there are two options. One is skip the next dose or reduce the opioid dose by 25% and then reassess. If the delirium improves, that is a clear indication that the delirious status is the result of opioid overdose. I repeat, if the patient is delirious and we are confused whether it is due to pain or whether it is due to opioid overdosage, skip the next dose or reduce the opioid dose by 25% of the already existing dose and then reassess. If the delirium improves, that is a clear information that delirious status is from opioid overdosage. So next is to restart opioid at a dose which is 50% less than the previous one, if it is due to opioid overdosage. On the other hand, next slide please. If the delirium worsens while stopping or reducing opioid dose, it again gives a message that the delirious status is because of inadequate analgesia. Then our next task will be to titrate the opioid dose to achieve satisfactory pain relief. While doing so, and if the patient is, we cannot go on, we cannot allow the patient to remain in a delirious status for a longer time. And we have to give a trial of neuroleptic together. Like what we do commonly is to administer 2.5 milligram haloperidol orally if the patient is able to take orally. Otherwise, 1.5 milligram haloperidol subcutaneously or intravenously to make the conscious status clear. If either way it doesn't work, we need to change an alternate. We have to choose another alternative opioid. Well, having said that, I am reiterating the fact that the present opioid drug, if it is going to be continued, it is not going to effect in satisfactory pain relief. At the same time, if it is going to put the patient on a delirious status, then it is not possible to achieve satisfactory pain relief with a clear conscious status. It is better to change to another opioid. Next slide. And coming to opioids in liver disease, we know liver is a major site for biotransformation for most opioids. And for most of the opioid analgesics, oxidation is the major metabolic pathway. But morphine and buprenorphine, it is not by oxidation, it is by glucuronidation. But plasma clearance of morphine is significantly reduced, half-life is prolonged, and bioavailability is increased in cirrhotic patients. This may not be that significant or clinically significant, important in a patient with mild chronic liver disease. But in a cirrhotic patient with cirrhotic liver disease, where there is no possibility of a reversal to premorbid status, these facts we have to account for. Plasma clearance will be affected, half-life will be prolonged, and the bioavailability will be increased. So that necessitates some dosage and frequency changes. I again emphasize that this is not common for all patients with liver disease. This is of particular importance for patients with cirrhotic disease. Next slide, please. And regarding methadone and fentanyl, they are heavily protein bound and require reduced dosing in patients with cirrhosis. But their metabolism does not yield toxic products. This is in contrast to morphine. Their metabolism does not yield toxic products, so they may be better tolerated, but actual evidence-based data are not clear. We lack many clear-cut evidence-based data. So, whatever literature I had searched, almost all literature give the same status. They may be tolerated. This could be reduced or this could be adjusted. No clear-cut data is available yet. But it is said that whatever literature I had gone through, they have, in all literature, it's mentioned that methadone or fentanyl are tolerated better because of lack of toxic byproducts. Tramadol converted by cytochrome P4, 3A4 and cytochrome P2D6 to O-desmedial tramadol. And cirrhotic patients with decreased enzymatic activities. So the metabolism of tramadol will be altered and analgesic properties may not be fully established. And we have to remember the following facts while using opioids in liver disease. Opioids should be administered. Those opioids should be preferred with a shorter half-life, with a longer interval between doses, and possibly to start with a lower dose. And this is of importance, particularly when raised prothrombin time and INR ratio, and low serum albumin, with individual titration to achieve optimal pain relief without significant adverse effect. And while administering opioids in liver disease, check for signs of sedation opioid-induced constipation, and early features of encephalopathy. Opioid-induced constipation cannot be overlooked as a common side effect. This is particularly important in a patient with decompensated liver failure. And immediate discontinuation of the opioids should be considered if any of these complications appears. And bowel movement is of particular importance in patients with liver disease while being on opioid. And coming to rather even more complicated areas like patients with addiction or substance use disorders. And let us look at risk of opioid therapy in patients with addiction. Addiction means we have to understand it in the proper way. Physical dependence will be common for many drugs. It is common for even hypertensives, oral hypoglycemic agents. So physical dependence is not a major problem. Tolerance is also different. We cannot get more confused with more and more terms like physical dependence, addiction, and tolerance. Addiction means unnecessary craving for the particular analgesic, in contrast to the level of pain and pain relief. So sometimes we have to administer analgesia for patients having substance use disorder. So what are the points to be considered? Inability to achieve effective analgesia due to opioid tolerance, adverse opioid effects when higher doses are required, aberrant drug behaviors including drug diversion. And goal of analgesic therapy is to ensure that opioid prescribing is safe, effective, and does not contribute to worsening of existing addiction. This point is very important. We have to get satisfactory pain relief, and it should be safe, should not produce unnecessary side effect, and it should not contribute to worsening of the substance use nature of the patient. There are certain guidelines recommended. How to select the patient depends on the prognosis of the illness. And in a patient with non-cancer illness, having substance use disorder, it is better to try with non-opioid analgesics and complementary therapies. But if the patient has got a malignancy, and if he or she is in the advanced stage of disease, we have to consider or we have to give weightage for the prognosis of the illness. And if the patient needs opioids for satisfactory pain relief, it should be provided. And status of addiction, whether he is still continuing the habit of substance use or whether he is already in a state of remission. And pain severity. Severe pain definitely warrants use of an opioid. And risk of adverse opioid effects. And there are general guidelines, general recommendations. Make a diagnosis with appropriate differential diagnosis. When we make a diagnosis, we have to think of other possibilities as well. Performing a comprehensive psychological assessment, including the risk of substance use disorders. So, this is something which we don't routinely do. Definitely, we used to assess the psychological component or status of the patient, and we go through the emotional aspect of the patient, but generally we don't go that much detail of the substance use disorder, and many of us skip that question, whether you are habituated to any kind of drug or alcoholism, and those aspects most of us generally skip. But this is very important aspect. And obtain an informed consent before starting an opioid, and let us make a treatment agreement, how we are going to proceed and where exactly we will withdraw. And conduct assessment of pain level and function before and after initiating therapy. So what is generally recommended is begin an appropriate trial of opioid therapy, just slower in onset and with longer duration, with adjuvant medications and therapies wherever possible. Reassess pain diagnosis, pain score, and level of function regularly. The 4 A's of pain medication, analgesia, activities, adverse effects, and aberrant behavior should be meticulously assessed and recorded. And along with analgesic use and analgesia, we need to periodically review the status of addictive disorder. The patient might have been in a state of remission, but at any time he is at risk of going back to the previous status. So this is very important. And document initial evaluation and follow-up visits. And general recommendation, of course, I never had an experience of prescribing opioids for a patient with substance use disorder. So these are the things which I gathered from discussion with my colleagues. In outpatient units, if you suspect that the patient had a previous history of substance use disorder, or if he is likely to go into that habit, limit the amount of drug dispensed per prescription. Usually in setup prevailing in many community centers in Kerala, we prescribe opioids for 3 weeks or even 4 weeks. 3 weeks, 2 to 3 weeks is a routine if the patient enjoys satisfactory pain relief on a particular opioid. This is because, considering the difficulty of the patient and the relatives to reach the particular palliative care unit and to get the drug. But this consideration should be weighed seriously if the patient falls into the category of people having substance use disorder. So we have to limit, never cross the prescription more than 1 week. May refills contingent on clinical attendance, and usually we give opioids, morphine or tramadol, on proxy visits as well. Suppose the patient is not well, if he is too frail to attend the clinic, if one of the care provider or the bystander comes to the clinic, we give the drug. But we have to see that the patient is there. We have to, and he is regularly using the drug for pain relief. Then only we can provide the refills. And involve family members and friends in the treatment plan. This also is very important. It is not a one-to-one business between doctor and the patient, or a nurse or the pharmacist and the patient. You need to talk to the family member regarding the potential problems of using opioids in this particular patient and getting them involved in giving medicine to the patient and checking the compliance and the number of tablets. And inpatient, these patients should be kept under close observation. It is recommended that daily urine analysis for toxic metabolites should be done. And there are few self-assessment questions before winding up. This is a small case history. 52-year-old man presents to the pain clinic with a history of chronic low back pain from degenerative disc disease and a current pain score of 8/10, secondary to a recent occupational back injury. He has been receiving morphine 15 milligram slow release preparation or orally twice daily for past 5 years. His father also had alcohol addiction, and he reports, the patient, reports occasional use of marijuana. And which one of the following is most predictive of this patient's risk of displaying aberrant drug behavior in response to opioid pain management? The choices are as follows: duration of morphine use, pain intensity of 8/10, current use of marijuana, and family history of alcohol addiction. That is for the group.
Mary?
Current use of marijuana.
Any other takers?
Vidya?
Pain intensity of 8 on 10, because if that was his previous score, this is his score now. Something's wrong.
All of them, Raji?
Over. And then at the most, I mean, all these factors have significant effect on predicting the patient's risk of being into the habit of substance use, but the most predictive is the current use of illicit drug. Among all the factors, it is shown that current use of an illicit drug of any category is most predictive of patients' risk factor. And next comes family history of alcohol addiction. Then only the morphine use comes to the picture. So that shows the importance of asking the history of substance use. I mean, this particular aspect I also noticed only while preparing the slides. We casually stops our queries with a question like, are you habituated to alcohol or cigarette smoking? That ends there. Okay. So the previous habit of, or the current habit of using other kinds of drugs or the substance is usually not done in our routine questionnaire or routine history taking. This is very important. Next one. 3 true or false questions. Very simple one. And Nandini, I should say, though you have recommended the analgesic use in thrombocytopenia, I searched hard, I couldn't find any specific articles pointing to analgesic use in thrombocytopenia. So I just put it as a question. So paracetamol
this was a question raised from the group. They asked for that, so that is why it was included as one of the
No
points.
problem. No problem. I will welcome that. That is the reason why I searched for it. So because I didn't get a clear-cut or specific answer, I just put it as a question. The true or false statement. Paracetamol and opioids are not recommended in thrombocytopenia. It is true or false?
False.
It is false, though there are very few case reports showing thrombocytopenia or fatally low platelet count after initiating opioid therapy and after initiating paracetamol therapy, but they are single or isolated case report. Only while I searched for the articles, I could find these details. And in one case history, it exactly happened for paracetamol, that was because of overdosage. And for one case history where opioids were the culprit, later it was found that it was antibody mediated. But generally, for a general consensus, paracetamol opioids are considered to be safe in thrombocytopenia, irrespective of the platelet count, whereas NSAIDs are not recommended because of the potential bleeding tendency. And buprenorphine and tramadol can be used in patients with substance use disorder. And if the patient requires opioid analgesia, and the patient gives us a history of substance use disorder, can these two drugs be used?
True. Can be used.
Buprenorphine sublingual, maybe not, ma'am.
buprenorphine patches, transdermal patches of buprenorphine and tramadol can be used. But the problem with buprenorphine and tramadol are both have ceiling effects. We cannot escalate beyond a particular limit. They can be used. If we are a bit cautious with morphine and methadone, buprenorphine and tramadol are alternatives. But both drugs have definite ceiling doses. While doing
also, Raji, buprenorphine is an important opioid agonist therapy drug. In a patient with substance abuse, they use buprenorphine because it has got a mixed
antagonist property.
So that's also there. So they cannot overuse it, or
correct.
Yeah, so
they
also
will
an
experience the advantage. And while doing opioid rotation, the previous opioid should be completely stopped before switching to new opioid.
Should not be completely. Because then the breakthrough will happen.
So, what should we do? Combining both the opioids? That is not according to the ladder, no?
You should start tapering off one and start the other.
Sure. Others left? I can see only a few people, or I can listen to few voices only. Others left?
They are there, ma'am, but they're quiet.
That is a false statement. When we switch from one opioid to a new opioid, what we do is usually we start with a lesser dose. So definitely the patient can have breakthrough pain. For breakthrough pain, we can use the previous opioid and we need to escalate the new opioid till the satisfactory pain relief is achieved and then stop the older one. So you don't have to continuously cut off one thing and start a new one. It is not the general practice. It is not the practice. Okay, we can start the new one at a lower dose. And for breakthrough pain, we can use the previous one. And once the satisfactory pain relief is achieved by titration, we can stop the previous one and completely switch over to the new one. Next. Which of the following is not a factor contributing to susceptibility to adverse effects to opioids? There are 7, I think. And which of the following is not a factor contributing to susceptibility to adverse effects of opioids? Concomitant medication, degree of responsiveness of pain to opioids, genetic variable.
Raji, ask one each and ask the answer, no, so that it's easier, because that sentence, the stem itself is it takes some time. So whether ask one and then ask one point and ask whether it's contributing to adverse effects. So that
okay.
Yeah. I mean, just one point at a time.
So should I read the question again? If it's not a factor contributing to susceptibility, the first is concomitant medication. Is it a contributing factor?
So it is false, right? Because it's not a factor, you have said.
I just want
Raji,
to know.
Your question is so
confusing.
It is not a factor contributing.
Not a factor. It is
and that too not to adverse effects, but to susceptibility to adverse effects. So,
see, suppose I am taking an opioid analgesic. Okay, whether I am susceptible to adverse effect of opioids, that is a question. I am on morphine. I am prescribed morphine. Whether I am susceptible to adverse effect of morphine.
If I also take other medications.
If I take a concomitant medication, that will contribute to adverse effect. That is the question.
It will.
So first point is it will. Yeah, the first.
It will. So it is a factor. It is a factor. Suppose if I am taking.
No, but you asked for it's not a factor. So that's,
that's why. So that is why I want you to identify which is not a factor. So it is a factor, no? It is a factor. It is a factor.
It's a multiple choice.
It is a multiple choice question. Oh, sorry, I didn't mention that.
Yes.
Which is not a factor. Okay. So this is a factor contributing to the susceptibility to adverse effect. If I am taking a medication, concomitant medication, which is susceptible to or add on to the adverse effect of opioid, I can have. And then degree of responsiveness of pain to opioid. You have prescribed an opioid to me. Whether my degree of, whether my pain, whether that is responsive to that particular opioid, is it a factor or not? Is it so confusing?
Can we give the answer straight away, ma'am? That way it is
no,
easy.
no.
Okay.
Degree of responsiveness should not be a factor, because the higher the degree of responsiveness, the lower dose will be used, right?
Yes.
Suppose Nandini, not Nandini, to the group. I have a severe musculoskeletal pain, and you have prescribed morphine to that pain because it is severe. For me, it is severe and it scores 8/10 or 7/10. Because it's a severe pain, you have prescribed morphine. Whether musculoskeletal pain is not musculoskeletal, muscular pain. If it is sensitive, is it sensitive or is it responsive to opioid?
No.
No, or if you have just mentioned degree of responsiveness, maybe if you had qualified it as high degree of responsiveness, then I would say that then very small dose of opioids are helping out with the pain, so probably there are less chances of adverse effects.
Okay. Oh no, I just put it as in another way, like if the quality of pain is different, and if that particular pain is, it was my assumption, and it could be read in a different way as well. That's only a difference. I mean, hope all others are catching up with me. The first factor was, the first response was concomitant medication. If I am taking an opioid, if I am using another medication like tricyclic antidepressant, definitely it can enhance or add on to the adverse effect of morphine. And the second thing, if I am prescribed an opioid analgesic and if I am taking that for a pain which is not responsive to opioid, if I am taking an opioid analgesic for a pain which is not responsive to opioid, definitely I am more susceptible for an adverse effect. And then genetic variability.
Yeah, it is a contributor.
Yes.
It is a contributor. Metabolic alterations, the difference in the metabolic pathway in different individuals, that contributes. And prior exposure to opioids.
No.
It's not a contributor.
Not a contributor. So that's the answer.
Okay, let us wait for the others also. Rate of titration?
Yes.
It is there. I mean, because if you titrate the dose faster, there is no time for the body to adapt to the effects and side effects of morphine. So that is the reason why it is said, though, probably we can read the analgesic efficacy of opioid, say morphine, after 24 hours. We need to wait for at least 48 hours or even 3 days to get a complete picture what exactly is happening. So rate of titration is very important, because if you titrate the dose faster, less time is available for the body to get used to the effects of opioid. And then renal function. If renal function is compromised, it is there. And the root of definitely adverse effect will be there. And route of administration? Comparatively less, no? For the intrathecal and the spinal epidural routes, adverse effects are comparatively less because we need much less dose of morphine. The comparable doses are for epidural dose, we require only 1/10 of the oral dose, and for the intrathecal dose, we need only 1/100th of the oral dose. So because we require much lesser dose for an intrathecal or epidural morphine, the adverse effects also will be much less. To frankly speaking, there is no answer. Like, which is not a factor means all are factors contributing to adverse effects of opioid. None of the above.
What about prior exposure of opioid? Is that a contributor?
That is what the literature says. So once, I also did not get convinced easily, but the literature and the particular textbook says that prior exposure to opioids, that is.
The only thing I can think of is tolerance because of earlier exposure.
It could be the reason. They have not given a satisfactory explanation for that, but I will try to get more details. But they have said that all these 7 factors are contributing to susceptibility to adverse effects. So the answer is none of the above.
Okay.
That answer is not given anyway.
There is one important contributor in the list that is not seen, that is dehydration.
Yes, it is true. Correct. Dehydration. And it is particularly important for NSAIDs as well.
Which is also not the answer. Like it is the contributor.
It is a contributor. I admit. And then that's all. Do we have time for discussion?
No.
No, but if anyone wants to ask a question regarding the topic, kindly ask. Yes.
People have run away a lot.
Yeah, maybe.
I'm talking about the same girl who I was talking about sometime back. Today early morning, she's on morphine infusion. She's 60 kilos and she was on a morphine infusion 2 milligram per hour and 500 mg paracetamol 6 hourly. But today morning at 4 a.m., she became delirious. And she started pulling out everything, and she's otherwise a very calm and stoic girl, taking her problems very well in her stride, but today she became delirious. So I was wondering whether this could be opioid overdose or could it be a hyponatremia or something like that. But then the doctor said it is not an opioid. In fact, he stepped up the dose of opioids and gave Serenase also. So this is just a question I just put up, like in such a case, of course, her liver function is also deranged a bit because of the high antibiotics and all that she's getting. She's a case of refractory ALL. So in this case, what could be the possible cause for the delirium in the morning? Sodium wasn't done, so I don't know the answer to that. But could it have been a morphine in view of the slightly deranged liver function? But what they did was actually they stepped up the morphine and she became stable. So was it underdose? It must have been pain. According to that, could she have had a real bad pain that she went into delirium?
Unmute, ma'am.
Okay.
In advanced disease, this is a very, very complex situation. And we will not be able to get the exact picture by just going through the score, because the child will not, in this particular case, the child will not be in a stage to give a proper answer also. So it's always better to, if you are suspecting that it is inadequate analgesia, always step up and see the response. Concomitantly administer a small dose of haloperidol as well, to see that whether the conscious status gets cleared or not. And hyponatremia is something which we can always find out, but in a dying patient, it is not an investigation which is worth doing. And slightly deranged liver function will not produce delirious status. renal for slightly deranged renal function may, but slightly deranged liver function will not produce that kind of delirious status. For that, that delirious status to reach, liver function should be really compromised or decompensated.
She had a slightly deranged renal function also. Slightly.
Then we need to. But anyway, the child has become better after stepping up
with
opioid.
More opioid. They give Serenase and increase the dose of opioid, and then she stabilized after that. Might have
Mary, I have something practical which I have observed. That is, in hospital situations, early mornings are the times for different duties, shift and changeovers. Very often the drips get discontinued because
infusion was going on.
That's what the infusion gets changed. Due to change of position, cleaning of the bed, etc. Sometimes there is a short interruption.
In this particular case, that was not the thing.
Okay, this is something that we need to keep in mind.
Yes,
as a practical point, it may not be relevant to this patient. Okay,
and that is usually described as the transition zone. The patients will be most neglected.
Yeah,
this duty changeovers are.
Sorry to interrupt. The Zoom time, the meeting time is up. It may cut off when we are talking, but if there is anything, you can always write in an email, and we will do a chain emails where we can answer each other. So we can discuss now, but it's going to be cut off.
Yeah. Thank you everyone who has stayed back. I can see there are 10 participants. I think we began with 19, but of course we have. But it also shows that the discussion was prolonged because of interactions. That's, I think, acceptable. Now, amongst those who have stayed back, are you all having any? Are you all having patience to give us as case presentations like how we are doing today, or last few times? Please continue to send cases for discussion. As many as you have, it doesn't matter. We will just collect them, and we will bring up different aspects of discussion in each of the eco meetings. Okay, Betty, Sipla, Akhil, Farzana, it will be great to hear from you. So send patient discussions, okay? And Vidya would be sending some questionnaire, this time to everyone?
Yes, ma'am. Yes. I'll be sending a feedback questionnaire. I think I'll send it in the email, ma'am, because only few participants are there now. I will describe what to do with the questionnaire because it's been 5 sessions now. We would like a detailed feedback so we will know what is happening and what we can improve and everything. If it is okay, we will also do a personal phone call and we can talk with you. Is everyone okay with us calling you? Okay. Then we will also make a personal call to find out how you feel about it and where we are going wrong or whatever we can improve. Okay. Is it okay, ma'am?
Yeah. At least for those who are right now here, if you could indicate a time of the day when it is easiest, convenient for us to call. At least amongst those who are present here, we know when to call you. Others will have to call up and ask them when to call them.
Yeah. So evenings better or
just message your most convenient time in this chat.
That's enough. Evening or during the daytime, anytime.
Thanks a lot. Yeah. Thank you, Vidya.
Thank you.
Thanks.